Good evening, everyone, and welcome to our webinar. Today, we will be discussing recent updates on ERA, what we have learned so far, and where to go next. My name is Vivian, and I am the scientific advisor in the APAC region for Igenomix. And I want to say hello to all attendees joining us tonight from Southeast Asia, Korea, Taiwan, Japan, and even Australia and New Zealand. We are planning to start tonight's event with a presentation from Dr. Carlos Simón, and this will be followed by a Q&A session that will take place in the second half of the event. I want to remind you that there is translation available tonight from English to Japanese, so if you need access to that, all you have to do is click on the globe icon that is located in the lower part of your screen. Now, let me introduce to you our moderator for the night, Dr. Koichi Kyono. So, Dr. Kyono has been a leader in reproductive medicine for decades. Having learned about ERA from Dr. Simón himself, during a visit to Valencia back in 2015, he immediately introduced ERA to all his own clinics. Dr. Kyono, who also actively performs PGT and studies the microbiota, is a local authority on RIF treatments in Japan and has been making great achievements in the field. Welcome, Dr. Kyono.
Good afternoon, ladies and gentlemen. Today we have the honor of having Carlos Simón, and we would like to listen to ERA mainly today, endometrial receptivity analysis. This is the opening slide. Here, please find the term finding the endometrial window. And then here, today we have the maternal crosstalk issue. And so here, and the endometrial receptivity, ERA, and endometrial microbiota. Here, we'd like to focus on two things here tonight. Moving on, about ERA, about 70% of the women are receptive, and the rest of them, about 30%, are the non-receptive group. Next page.
And regarding the ERA, there are many papers published. And in 2017 and 2021, our papers have been also published. And, it is ERA supportive papers. Please go to the next. Recently, there have been some papers published, and these are against the ERA. saying that ERA is not effective. So concerning the ERA, we'd like to have a lecture by Dr. Simón. And also regarding those papers, we'd like to have his opinions. Another point I'd like to mention is that in the world, at the time of ERA, HRT cycles are considered. And in Japan, more than 90% is based upon HRT cycles. In Australia, it is 63% based upon HRT cycles. And in Japan, by using false ET, it is said that there is the attached the placenta cases increasing. Therefore, it's been shifting to natural cycle based. And that's the current status. And I would like to mainly hear from Dr. Carlos about ERA. And let me introduce Dr. Carlos Simón
of Igenomix, and he's a professor of University of Valencia, Harvard University,
and Baylor College of Medicine. And his main interest is the maternal endometrium and its cross communication with the embryo. Please start, Professor Simón.
Thank you, Dr. Kyono. Thank you for your kind introduction. So let me share my presentation. Is that okay? I understand that I can be seen and I can be heard. It's okay? Okay, I assume so. So again, it's a pleasure to be with all colleagues in Japan and Korea and all the APAC region, and thank you for interest on the ERA test and what we learned now after more than 10 years of use, and this is what I would like to address to all of you. First, let me just disclose that I've already stepped out from Igenomix, so my presentation can be seen as an independent person because I have my own foundation. I work in Carlos Simón Foundation for Research in Women's Health, and I have created some startups, and I act as the external scientific advisor of several companies, including Igenomix. So you have to, this is my disclosure. And what I would like to cover in this presentation, and then of course the questions that we will go through, it will be, first, I would like even to discuss with you whether the endometrial factor exists in the light of a recent paper that I want to comment. And then I would like to mention, to gain knowledge about the microbiome as another possible cause of recurrent implantation failure, together with the biological plausibility and clinical data regarding ERA and his surrogate treatment, personalized embryo transfer. So this will be the main points of my presentation today to all of you. First of all, what I would like to just have some clear concepts to start with. And these concepts are that we should distinguish between a failed cycle, which is a implantation, or what we call that implantation fails. We have to distinguish between these and recurrent implantation failure. Humans, we are very inefficient in reproduction, and we know that if we transfer one embryo, implantation rate will be about 40% in the best scenario. Therefore, implantation fails in 60% of cases, and so on if you transfer more embryos. This is what our system in humans we have, because as we know, embryonic implantation is quite inefficient, and this is just 1/3, 40% of embryos will implant at the first attempt. And this is just the regular patients. However, it's different when we consider recurrent implantation failure, which is a real issue, and we know that it exists. Recurrent implantation failure are those patients with low chance of pregnancy per embryo. They are below the normal average, and that's why some societies, the concept that we have is that they fail 3 or more embryo transfers with high quality embryos, or more than 10 embryos in multiple transfers. So I just mentioned here ESRE definition, but several societies can give different definitions. But at the end of the day, it's a different situation. It's patients that they fail 3 cycles and they have a low chance of pregnancy. So we have to distinguish between these 2 entities. So going from that, let me just comment on this paper that we have in ISR with Dr. Scott, in which basically they in this paper, they say that the rate of true recurrent implantation failure is low. And the point here is just if you transfer euploid embryos, everything will be taken care of. So I discussed with him this situation. First, in this retrospective paper, they say rate of true recurrent implantation failure. But when they analyze the patients, the inclusion criteria for this true recurrent implantation failure retrospective study was this age, normal BMI, 12 oocytes, 5.5 blastocysts, 3.5 haploid embryos, morphologically normal uterus, hysteroscopically normal uterus, endometrial lining more than 7 millimeters. So my comment, this is not a recurrent implantation failure population. In fact, when they transfer the embryos, as you can see, in the first embryo transfer, they got 64%, second 54%, third 54%. So the point is that they are doing a recurrent implantation failure study in patients without recurrent implantation failure. It's like if we go to find the rate of true poverty at Wall Street. We will not find many of them because this is not the place where this niche of population exists. So this is the first thing. The second thing is when we analyze the figures, the message that they give is that the result of 3 successful frozen haploid single embryo transfer, they reach 95.2% of pregnancy rate. This message is misleading because when you see the picture, when you see the figure 1, as you can see here, once they have their first embryo transfer, they'll drop 43% of patients those that fail lose those patients for statistics. In the second embryo transfer, more than half of the patients, they were lose for the statistics. So at the end of the day, they were losing all of these patients that they do not count in the statistics. So these 95% are from those patients that remain in the treatment for 3 cycles that they do not abandon, but 50% abandon in the first, more than 50% in the second cycle. So at the end, data can be telling us many things, but this is common sense. See, if a patient does not follow 3 cycles, you cannot count them as part of these numbers. So this is just to emphasize the point that clinically the endometrial factor exists. The endometrial factor exists, and we cannot say that recurrent implantation failure does not exist because we have plenty of data showing that the rate of recurrent implantation failure represents 15% of IVF cases, the most difficult patients, and that's why we created the ERA test for that. So this is just to distinguish the failed cycle and recurrent implantation failure, that this is about between 10 and 15% of all the IVF cycles. So the point is, we have been working on this very space for more than 30 years, trying to see what can we fix in order to improve implantation failure. And we came with the window of implantation that we will discuss with the ERA test, and we come with the endometrial microbiome that is present when the embryo arrives to the endometrial cavity. And I think that there are plenty of data about that, and even now there is a clinical study coming from Japan showing that clinically you improve results by analyzing the microbiome and just treating dysbiotic endometrial microbiota. But let me go very fast on this, and we will concentrate on the ERA test. In general terms, the point that I want to make is that we are moving now from generalized medicine based on population average, which means what is better to transfer day 5, day 6? What is better to have embryos day 2, day 3? This is old-fashioned, and this doesn't work. Today, we are working on precision medicine, and this is based on each person's individual biology. This is not about a technique itself or even a disease. It's about the patient itself. So the use of molecular diagnostic tests to determine which medical treatment will work best for your patient is what is gaining momentum. And we are using this frequently in oncology and other big medical specialties. And this is what is getting introduced in reproductive medicine. Those are not add-on. These are precision medicine tests that will help us to really flatten cycle. It's not about through embryos, blinded nowadays in the uterine cavity. It's about to know what is the issue in the uterus of your patient. And this is what I would like to comment on that. First, endometrial microbiome. The endometrial microbiome, we have been working on that for a long time, we and other groups, showing the existence of an endometrial microbiome, showing the microbiome of a pregnancy, of an initial pregnancy, and what is the difference between miscarriage and pregnancy. And we have ended up with a big study demonstrating the association between the endometrial microbiota composition and reproductive outcomes. So you can see that from our group, and this is from the group of Dr. Scott also and other groups. And as said, we have finished with this study that was published this year, by which endometrial microbiota composition is associated with reproductive outcome in infertile patients. There were more than 400 patients in 13 different, by which they were obtained an endometrial biopsy, an endometrial liquid, an endometrial fluid, and then they went to an IVF cycles, and after that, we just make the association between good outcomes, which is pregnancy and baby at home, and outcomes, which is no pregnancy or clinical miscarriage. And what we learned from this paper that you can see it published is that there is a signature of pathogens that they are present when we have poor outcomes, meaning no pregnancy, biochemical pregnancy, or clinical miscarriage, both in endometrial fluid and endometrial biopsy. So those pathogens are present, and we have an endometrial and a dysbiotic endometrial microbiome. On the opposite, those are the signature of microbes that they are increased when the live birth compared to poor outcomes. As you can see, lactobacillus is always present and is the main bacteria present there. Altogether makes the point here that the endometrial microbiome exists, is associated with reproductive outcomes. This was a prospective observational study, but I am aware that there is a study coming from Japan that they intervene and they treat the patients accordingly to these results from the microbiome of the EMMA test, and clinical results are better compared to controls. And you will see this published very soon in JAMA. And then the next step is, once we have the microbiome is on the surface of the epithelium, and this is what the embryo is just watching when it enters in the endometrial cavity. But then the embryo has to adhere to the endometrial epithelium, has to attach to this epithelium, and this is because the epithelium changes, suffer what we call the plasma membrane transformation. Without this transformation, the trophoblast will never attach to this, because the human embryo is able to adhere to any surface that you can imagine. Any surface can adhere to the epithelium of the tube, and you have an ectopic pregnancy, to the peritoneum, you will have an abdominal pregnancy, can adhere to the plastic of the transfer catheter, and then your embryologist will tell you, doctor, you have to repeat the embryo transfer to go back again. But a blastocyst will never adhere in a non-receptive endometrium. And we know this in the clinic. If you transfer an embryo and the patient has not taken progesterone, forget it. It's not going to happen. We will never transfer embryos in the follicular phase or late in the luteal phase. So we know that the window of implantation exists, and this is the main limiting factor for the initial part of the implantation, which is the addition of the embryo to the endometrial epithelium. Therefore, we have been trying to understand how to recognize, how to identify the window of implantation in the endometrium from the anatomical medicine, the Hertig criteria, to the molecular medicine. The Hertig criteria did not work, so 20 years ago, we started with other pioneers like Peter Rogers and Linda Judis to trying to use the transcriptomics, to trying to use the transcriptomic signature to have a different Google glasses, different glasses to see the endometrium, but now in an objective manner, seeing what transcripts, what RNAs are produced and what are just shut down in order to learn when the receptivity, when the window of implantation was. So we went on that a lot, and it was on the issue, taking the whole endometrial biopsy, and we create the signature to identify the window of implantation, and that's why the ERA was launched about 10 years ago. Later on, we went on and trying to again check this signature, but now at the single cell level. As technologies evolve, we have the possibility to do this transcriptomic signature, the whole transcriptome, the 34,000 genes, but now at the single cell level, cell by cell. So we published this paper 2 years ago in Nature Medicine, studying more than 70,000 endometrial cells from 29 healthy ovum donors throughout their menstrual cycle. And what we learned from that is that, as you can see now at the single cell level, you can see those colors here, that there is a change, an abrupt change of colors when we open the window of implantation. So those genes are completely turned on here, those genes are completely turned off here. So this is an abrupt change that exactly recognizes those main genes involved in the ERA test. So this is a difference what happens in the stroma, that the decidualization is a more subtle process. There is not such an abrupt step here that we can recognize. So somehow this was the plausibility, the biological plausibility of the recognition of the opening of the window of implantation. Because of that, we just went on and trying to understand at the clinical level what patients will benefit the most to identify this, because as said, this is precision medicine. So we have learned that 70% of patients using the ERA test, we can identify the window of implantation after 5 days of progesterone administration, either exogenous or endogenous. 120 hours of progesterone administration, which means progesterone receptor activation, the window will be open. But in 30% of patients, the window will last more days. It will be open later or earlier as before. And in some patients, mainly those with uterine congenital abnormalities, the window will be narrow. Typically, the window will last 30 hours, but we have seen windows even of 12 hours. But typically, it's about 30 hours. But when you are in the middle of the window, you will be better off in order to have adhesion. This is what we have learned. And that's why we created the concept of using personalized embryo transfer after ERA diagnosis as a treatment for recurrent implantation failure of endometrial origin, with a very straightforward concept, which is transfer the embryo not only when the embryo is ready, but also when the embryo is ready, but also when the personalized window of implantation of your patient is there. So this is the concept. Now, this was the very first prospective study that we published about 10 years ago, showing that it could be used for patients with repeated implantation failure. Our most difficult patient, showing the concept of transferring blastocysts at day 7 or at day 4, depending on the displacement of the window of implantation of the patient. And this is, for instance, the very last paper coming from China, I think, in which this is the clinical outcome of personalized embryo transfer versus frozen embryo transfer in patients with recurrent implantation failure. You can see the ERA group is 50% clinical pregnancy rate versus the frozen embryo transfer group, and implantation rate goes from 41% to 18.8%. So this is the very last retrospective study published about the efficiency of ERA in recurrent implantation failure. all the data that you can find about the clinical publications, you can see in this paper that I published last year in Reproductive Medicine Online. This is table 1, in which there was 16 positive papers, 6 negatives. Nowadays, if you look in the literature, there are 22 positive papers and 8 negatives. But this is not like a matching. This is I just informed you about the data existing in the literature nowadays. But I think what we try to learn here is from evidence-based medicine. And the best proof of evidence-based medicine is the meta-analysis. So I show you here this paper coming from China. This is an independent systematic review and meta-analysis by which they analyze the clinical efficiency of personalized embryo transfer guided by ERA. They distinguish basically 2 groups of patients. Those patients with good prognosis, 0 to 2 prior failed embryo transfer, and those patients with poor prognosis, with 3 or more failures of that. This is all the data in the literature at the moment of publication. And what I can show you here is that when they analyze patients with recurrent implantation failure after doing ERA, the message that you can get from the paper is that personalized embryo transfer guided by ERA significantly increased the chances of pregnancy for non-receptive patients with recurrent implantation failure of endometrial origin. And this is considering all the papers that they were published until this moment. This is for patients with recurrent implantation failure more than 3 prior attempts. What about good prognosis patients, what they found in the literature analyzing this sample size is that those that do not use ERA, the ongoing pregnancy rate or live birth was 39.5, but with ERA was 53.7. But this was not statistically significant. Therefore, the message is that for good prognosis at this moment, there is not a statistical significance difference in terms of live birth rate. The papers published regarding good prognosis, we publish our randomized clinical trial in good prognosis patients. After we learned that they was useful in our most difficult patients, we try to see at what extent it could be useful for patients with good prognosis. And in this study, because we have a high dropout, more than 40%, intention to treat, we did not see differences. But when we analyze patients per protocol, which means those that follow the protocol in terms of adhering to everything that should be done properly by doing an ERA and then transfer the embryo, we learned that implantation rate in personalized embryo transfer increases 14 percentage points compared to frozen, 18 compared to fresh. Pregnancy rate increases 18 points and 14 points respectively. Same for relative pregnancy rate. And live birth rate, it was increased 13.8 points versus frozen and 10.5 versus fresh. So we indicated here that because the study was powered to detect 15% increase, we cannot say that there was a statistically significant increase in live birth. But in all the other parameters, the protocol analysis, we found these differences that it really improves clinical results. This is the only randomized clinical trial published. We have, Igenomix has sponsored another RCT that was performed by Sherry Grove, which is the one that the abstract was published. The paper is not published yet. They performed a study with good prognosis patients transferring chromosomally normal embryos, and it looks like they did not see an increased results in this type of good prognosis patients. But again, the paper has not been published yet. Now, sorry. there are two papers that recently come that this retrospective study by Cozzolino, which is the EB group. This is a retrospective study in which basically they show that they did not see any improved results of personalized embryo transfer versus frozen and fresh. And it is interesting because this study has been done in the very same center when we perform our randomized clinical trial. And what I can offer you, and I'm going to show you the letter of the editor already submitted and accepted, is that these are the results that we obtained in the very same page. So this is in the same center, in the same patient population, on the same topics, and we have different results here. So as you see, these are the results that we obtained with personalized embryo transfer. Pregnancy rate 73%. However, what they brought is 40%. Implantation rate, we have 61%. Those are the EB patients participating in a randomized clinical trial. They do not have implantation rate. They have a range of implantation rate here. Live birth rate, they report 18%. However, we have 55.6%, and so on. So the point here is that when they analyzed the retrospective study, interestingly, they omitted the patients that they have been treating in the same center and they were in our study. So in this study, this is a retrospective study, they include every patient except those patients in our randomized clinical trial, which, as you can see, there were 45, again 88, so the number could be really improving that, and maybe the results will change. So because of that, and because this is a retrospective study, we just sent this letter to the editor that has been already accepted, in which the main points that I want to make here is that, first of all, in this study, as mentioned, in this study, there is, they exclude those patients that they were in our randomized clinical trial, and their argument was that they were not managed under clinical routine practice. But ERA is not a routine practice in prognosis patients. Therefore, this exclusion criteria arbitrarily eliminates patients following a stringent protocol from an evidence-based experimental design with good results. So, since 35.7% of patients for EB did not follow the proper protocol in our randomized clinical trial, the percentage of non-compliant patients in this retrospective study remains positive. The second point that we made on this letter to the editor is that, as any retrospective study, and this is even worse, they compare an unbalanced patient sample size, 10% versus 46 and 42. And they 10% because they excluded our patients. So, and use a parametric test without normalization. We did not see any baseline demographic information other than BMI, years, and fertility and age. And there was no data on embryo in non-PGTA patients. However, there was a significant lower numbers of embryo transfer in personalized embryo transfer versus the other arms of the group. Finally, we did not see any evidence to ensure reproducibility, including our deviation between ERA recommendations and PET performance, endogenous progesterone, exogenous progesterone intake, or consistency in the luteal phase. The authors adjust odds ratio using logistic regression, but results are not shown. Therefore, we cannot know at what extent confounder variables were differentiated into this model. And finally, we mentioned that the discussion carries bias because only mention those patients with unfavorable results, neglecting 22 out of the 30 published studies with superior ERA-guided PET outcomes. This is what I can say about these studies. And finally, from this meta-analysis, the point here is that this is the data from recurrent implantation failures that by having ERA incorporated, you got about 48.7% ongoing pregnancy rate, which is basically what you have in patients with good prognosis with no ERA. So somehow in patients with recurrent implantation failure, we normalize the situation to a to a normal situation, because as said, the RIF is a pathology. It's not like the repetition of cycles. Therefore, what I want to make here is that anytime that we have a new technique, there is always the same scientific innovation phases. First, when you show some technique, there is a panacea paradise. Perfect. This is useful for everything. Second, it comes the harmful hell. Those doctors know coming that this is apocalypse and this is useless and you are not going to be useful for anything. But finally, with the time, and in our case, the timing can be shown by the meta-analysis and the reflection of all the papers published throughout the world in the last decade, you achieve to specific indications for a specific test. And in this case, what I can tell you is that the meta-analysis and the data coming from all over the world indicates that personalized embryo transfer guided by ERA significantly increases the chance of pregnancy for non-receptive patients with recurrent implantation failure of endometrial origin. We have lived this also in PGTA. When PGTA started, everything was perfect, it was fine. The euploid embryos were wonderful and we have to do it for everything. Then it comes the harmful help from an editorial in New England Journal, from the paper, a classic paper that shows that we are harming the embryos. And nowadays, the reality is that 50% of IVF cycles in the United States are using PGTA, and at the end of the day, results is what matter. There are different agendas from different type of stakeholders, but at the end of the day, what works will stay. And doctors, we know what works for our patients, because once we try, we will learn what type of indications we should use the different techniques. So this is always what I tell you. This is about you. And always we have the innovators that when a technique comes, they start to use. Later on, we have the early adopters, and finally comes the early majority and then the late majority. But we always will have those laggards that they will never go for this, because this has been done previously always. But once a technology just reaches more than 11% of adoption, the rest will flow, and slowly will be adopted if we see that there are benefits for our patients, of course. And finally, this will be about what do you think is your role? Because as in everything in life, you can think in going ahead, stay at present, or go back. Those that go ahead means research, innovation, trying to improve. Those that go back is trying to deepen innovation and just saying that those are adds-on and they are nonsense. So it's better to repeat and repeat cycle. I can tell you that this is a waste of time, because the progress is going to pass through all of this. And time and experience really demonstrated that. So with that, I just want to thank you for your attention, and I just want to let you know that this work has been possible because they worked for 10 years at Igenomix with a very nice group and a very enthusiastic and smart group. But nowadays, I am creating my own foundation in which we work in women's research. In women's health research, focus on the uterus, trying that the pathologies affecting the uterus will no longer be an impossible barrier. So thank you for your attention, and I will be delighted to answer any questions that you might have.
はい、シモン先生、どうもありがとうございました。 それではですね、これからQ&A のセッションに入りたいと思います。で、質問の1、入りますけれども、Question 1. Would you summarize when and to whom we should recommend the ERA test?
With the actual data that we have, and I have been explaining to all of you, at this moment, ERA is indicated for patients with recurrent implantation failure of endometrial origin. This will be the main indication at this moment until more studies in good prognosis patients will let us know at what extent every patient can be included or not. But for now, in this meta-analysis, this is the main conclusion.
Next question. Question 2. How come there were so many dropouts in your RCT study? Is it really that difficult to follow your test protocols?
Yeah, those of you that have done clinical studies with us, they know how difficult it is to follow randomized clinical trials, because once you explain to a patient what is the treatment that has been assigned to, some patients they do not want to follow, and they have the right to step down from the study at any moment. So this is something that we encounter, and the study was, the length was 5 years. We have this high dropout because the patient stepped down for different reasons. That's why we present our results by intention to treat and per protocol. And that's why what I mentioned about this retrospective study from EB, in EB we have this 35% of patients that they step down from the RCT. So to analyze this in a retrospective study could be really puzzling. So the main reason is that clinical studies has difficulties always, and but that's why we analyze by the two ways, per protocol and intention to treat.
Question 3. How much influence does P4 level have on ERA? Igenomix recommends to make sure endogenous P4 should be lower than 1 nanogram per ml. But sometimes patients get pregnant even when their P4 becomes higher than 1 nanogram per ml in transfer cycle. How do you explain that?
Okay, we talk about different issues. So the window of implantation is open because the activation of the progesterone receptor. In order to be activated, you have to have progesterone at a certain threshold. If you just reach more than 1 nanogram, 1.2, 1.5, depending on different countries, on different assays, at this moment, you start to activate the progesterone receptor. Keep in mind what happens in your patients that are stimulating, and prior to the oocyte retrieval, the patient reached this 1.5 2 nanograms per milliliter. What you do then, you do not transfer the embryos. I mean, you just go ahead, we just freeze them, don't transfer in a fresh cycle because it will not work. So this is the same example. If you reach a specific cutoff of progesterone, the progesterone receptor is activated, and then you will have the window of implantation, and this will change what is the situation in the physiological issue in your patient. So that's why every time that we start an HRT, we give estrogen, and then prior to give exogenous progesterone, we measure endogenous progesterone to be sure that there is no any escape of progesterone, and then we add the exogenous progesterone, and then we know that the window will be open after 120 hours. If at that time progesterone is high, then the whole program is already activated and it will be opening the window soon or later. So that's why we want to be consistent using HRT, giving and then prior to endogenous to exogenous progesterone, we have to measure endogenous progesterone. I don't know if I explained myself properly.
Question 4, okay? Have you ever used your assay to find out how wide is the implantation window? Does it vary with age or between natural cycle and HRT cycle?
Yes. We have done, in fact, we have published the difference between natural cycle and HRT cycle. We're quite close. LH plus 7 is quite similar to progesterone plus 5. But regarding the length, it's impossible. In one patient, you cannot do many biopsies to find out how wide is the window. Typically, we know that the window is about 30 hours. But let me show you one thing that has been published, and this is can be quite demonstrative of this. Let me share with you this. Can you see my deck? Can you see it? Yeah. Okay. This is a study of Yark, and they claim about intrapatient variability of ERA tests. And when we learn, and this is, of course, we answer to this, and you are going to see here two types of, this is one patient that was done, the ERA test was done, and you are going to see in the upper part, the Igenomix initial prediction, and then and in the lower part, the biopsies performed by the author of this paper that they were somehow challenging blindly our predictions. So when they have the first progesterone, the first biopsy, and the first biopsy, this was done by the authors here, we predict it was done at 106 hours, and then we say this is a pre-receptive at that moment. So we recommend that the second, this was at the time, but that we need 2 biopsies to find out the window. So we recommend to the authors to do the biopsy with 154 hours. But the authors, instead of doing this, what they did is that they obtained the second biopsy here after 194 hours. And it was blinded to us. We did not were somehow indicated that they are going to do that. So then we say, no, this is post-receptive. You have to get closer to the window. Then they did the third biopsy in here, and we say, no, you have to go for 146 hours. And at the end, this is what they did. And then this is the fourth biopsy that they did, and the patient was receptive, and the patient was pregnant. So the point here is that by doing this, you can recognize that we are able to really identify where the window is, because at the end of the day, this is an algorithm, this is a number of genes that we have identified, and we show where the window is. Even if you can trick the system, at the end of the day, we show where the window is. However, the fact that we indicate where the window is doesn't mean automatically that the patient will be pregnant. Could be another factors, could be dysbiotic microbiome, could be an aneuploid embryos, or could be new things that we are not aware at this moment. But at least, as you can see, for recurrent implantation failure, this could be one possibility really to improve the situation in those patients.
Thank you very much. And question 5, could you share more data of natural cycle? Natural cycle.
Yeah. the problem of natural cycles is that natural cycles are not consistent. So the fact that we do a ERA test on LH+7 in a natural cycle, the issue is we don't know what is going to happen in the next cycle. Keep in mind that the ERA is done the cycle before. So the main problem is consistency. I know that many people want to do a natural cycle. In this case, what I suggest you is to go for LH+7, but you have to measure LH in blood to be sure that the LH is getting a start. I mean, it's getting at the top of the hill, not just getting started or after that. So we know what are the difficulties of a natural cycle, and that's why we always suggest to go for HRT cycles that are consistent, and the patient is not subject to different tests at different days, at different moments to find where their natural cycle is. Because in addition to that, if the patient is more than 40 or has this natural cycle could fail, could be inconsistent. So that's why we again suggest to go for HRTs.
Thank you very much. And you explained about MR. And one question, and how effective is the antibiotic probiotic treatment recommended by the MR test? How can we be sure we are really depopulating the uterus with lactobacillus?
Thank you. This is an important question. Antibiotics, they are effective if they are properly indicated for the appropriated pathogen. For instance, if we identify Gardnerella, we shall treat them with a specific treatment. We cannot use amoxicillin for Gardnerella. So we know that once this is identified, Gardnerella, metronidazole, Streptococcus, and this is the first thing that we have to do is just eradicate the bad pathogens. After this happens, then probiotics can be used. But probiotics alone by themselves is not going to solve a dysbiotic microbiota. Because if we give probiotics, which is lactobacillus, and Gardnerella is there, Gardnerella will continue being there and will produce the effects that dysbiotic microbiome produced. I can suggest you one of our papers that we follow a patient with Gardnerella for years, and we were unable to remove it because it was from a specific cladus and produce a biofilm. So this patient has 3 miscarriages, 1 ectopic pregnancy, and we were unable to make them pregnant because Gardnerella was there and we could not remove that. Therefore, the most important thing is to remove the pathogen and then to add the probiotic, the lactobacillus.
Okay, and next question about microbiota. We are aware that there are interactions between microbiome and immunity. That means microbiome has an influence on WOI too.
This is a very important question that we have tried to solve during the years with our colleagues in Japan. Our initial response to that was that maybe they were independent. One thing is the window of implantation and the other is the microbiome. But actually we have studies in progress that is indicating us that indeed the existence of a dysbiotic microbiome can modify the window of implantation. So indeed, this could be the case. Prior, we were not, we do not have proof of that, but and it was our colleagues in Japan and yourself, you were very interested on that. And since the beginning, we tried to find out. And what I can tell you is the data nowadays is not published yet, but it's really suggesting that there is a relationship and impact on a dysbiotic microbiome and a displacement of the window of implantation. We are doing this study now at the single cell level. obtaining the endometrium, disaggregating the cells, and doing this and find out what genes could be affected when we have a specific dysbiotic microbiome that affects the window of implantation.
Thank you. Last question. What is the future for ERA and uterine microbiome?
Can you repeat the question, please? Can you repeat the question? I didn't get the...
Oh, I'm sorry. What is the future for ERA and microbiome?
The future of ERA and microbiome? Well, the present is now the possibility to assess these two possibilities, the existence of an altered microbiome and the window of implantation. The future, as I foresee, is to going non-invasive, is to be able to do this, but not in the biopsy, but in the endometrial fluid, as we demonstrate in this paper published in Microbiome. The microbiome can be found in the endometrial fluid at the same extent that in the endometrial biopsy. And therefore, the future to be able to get this in the endometrial fluid for both of them and being able to have them prior to implantation, not the cycle before, but as close as possible. So we cannot wait for that, but rather can be done during the cycle. This is how I foresee that. We're trying to work a lot on ERA non-invasive, but the main problem has been the consistency, and that's why until the moment that I left Igenomix was not launched, because it was not consistent, the ERA signature in the endometrial fluid compared to the endometrium. For the microbiome, it is consistent, and hopefully the future, I hope that they will be able to do it non-invasive in the very same cycle, so you can have an endometrial fluid that does not affect implantation and have the result of the microbiome of the window of implantation and go ahead with the transfer.
Thank you very much, Dr. Simón. You talked about microbiome and ERA. Thank you so very much for your wonderful lecture. Today, he deployed the reputation. So there have been the opposing ideas or opposing papers, two of them, and I think he talked about his own ideas for that. And I think we are all convinced of the positive effect of ERA. So we have placed the confidence in this. But as was mentioned in his presentation, RIF or the repeated implantation failure is not only determined by the ERA of the microbiome or others, maybe the thyroid diseases could be, or maybe Th1, Th2, or the immunological factors might be related to RIF. So as a clinician, maybe we could use ERA and microbiome for sure, but maybe you might want to look at other factors, for example, the endometriosis, chronic endometriosis, or the immunological factors. So you have to go into the various factors, the potential factors to work on the treatment. Thank you so very much, Dr. Simón.
Thank you very much, Dr. Kyono.
Hi, everyone. The time is up and we are approaching the end of the webinar tonight. I want to, first of all, thank both of our speakers. So thank you, Dr. Simón and Dr. Kyono. It was certainly a very enlightening and interesting discussion. I'm pretty sure everybody in the audience could draw a lot of interest and insights from everything that was presented here today. I want to thank everyone in the audience for joining us. we will have future events, and we will take all questions into consideration and try to answer them later as best as we can. Please do not forget to answer the survey as you exit this webinar, because this is very, very important, so we can cater an even better events in the future, in the next time. Thank you, everyone, and I will see you soon.